Let's continue part of the thoracic trauma. Now we talked about chest wall injuries and pulmonary injuries. Cardiovascular trauma, it could happen to the myocardium, it could happen to the aorta, it could happen to the superior and inferior vena cava. Now, if we have injuries to these organs and these blood vessels, it might not be so easy if there's multiple injuries, and this is a multi-system problem, to figure out what's going on. But let's just isolate it for just a minute. If it is a myocardial injury, it could be potentiating that the fluid is building up around the myocardium, in that it builds up within the pericardial space. This is a sac that lines over in the pericardium, the pericardial sac, and usually there's at least 5 to 10, 15 maybe cc's of fluid to allow the heart to swing as a pendulum, if you will. And any more fluid, an acute presentation, will cause it to compress the heart, decreasing the volume into the left ventricle. And the left ventricle is where we really want to look at, but any compression onto the right ventricle, as we know, fills and feeds the left ventricle. So if we have more volume, increasing that potential space in the pericardial space between the visceral and parietal pericardium, if it compresses the right ventricle fails to feed the left ventricle has less, it's being compressed, it has less to fill, less output going. Go back to fixed principle, which let's change that. It goes back to more Starlings, where the larger stretch, the bigger the output. Now, if you have pericardial tamponade, we have increased JVD, we have muffled heart sounds, we have smaller EKG findings. This means that the voltage on the EKG is quite small. Alright, so if there's any other injuries to the great vessels or transection of the aorta, we definitely see the person exsanguinate quite quickly. This is usually a twisting or shearing force that occurs in an abrupt stop. So somebody that went on to a head-on collision and potentially was unrestrained and allowed their the movement as the second impact moved forward, and the third impact caused the heart to swing forward. And remember, the heart is just dangling as like a pendulum. It is attached to itself by ligamentum arteriosus, and it's slightly attached by the pericardium to the diaphragm. And so we can have this kind of twisting and tearing, and it can twist and tear right just there at ligamentum arteriosum. Now remember, ligamentum arteriosum was off the aorta, and it was this bifid exchange through the pulmonary circuit. Remember, as we saw, the pulmonary vasculature attaches itself in fetal growth. So it may tear right there and cause that transection of the aorta. If we do have that, you're more than likely going to have somebody that sanguinate quite quickly. And it's just based on the mechanism of injury. As far as the vena cava goes, it may be penetrating trauma, be a high index of suspicion to think about that in the chest wall, or even some kind of high velocity impact where fragmentation causes laceration of the vena cava, either superior or inferior. Now, to go back again, so chest wall injuries, usually if it's a flail segment, we want to kind of put some kind of bulky dressing to compress those areas so that it doesn't pop in and out, paradoxical movement with respiration, so that we have adequate inspiration, adequate oxygenation, adequate exhalation. When it comes to pulmonary injuries, we have to consider that if there's significant enough trauma, that there could be injury to the lung parenchyma. That is the vital parts of the lung that allows oxygenation and exchange of the vital gases to occur, and if there is some type of injury to that area, we won't be getting that exchange. So you need to give high flow oxygen concentrations, maybe even assist ventilation so that you can keep that alveoli open. As we know that there is some splinting or guarding as far as breathing goes in either one of those cases, a flailed chest or a fractured rib or a musculoskeletal type injury in the chest wall. The person does not want to take deep breaths, which will cause the alveoli or smaller airways to collapse, and more likely when the alveoli collapse, it's called atelectasis, and we just don't get that recruitment of alveoli enough to cause that gas exchange. Now when we move into the myocardial, let's go back as we move into the pneumothorax. As it develops, we are causing positive pressure to, while we ventilate them through a bag valve mask or CPAP or any device that you're forcing pressure in, you're causing more air to increase that space. So as we increase that space, we compress the other lung, we compress the myocardium, we compress the great vessels, and we'll end up seeing certain things called JVD and ventricular shift and hypotension and subcutaneous emphysema and the like. We'll see all those signs and symptoms of a tension pneumothorax, but prior to that, we need to make sure that we are at least understanding that we need to decompress the chest so that we can release that pressure. And if you think about it, with multi-systems trauma, the patient is bleeding out or bleeding somewhere else internally, hypotension is not something that's going to be a great indicator to tell you that the person has a tension pneumothorax. So you really have to be keen and watching on this. Now, they all be tachypnic. It all depends on just what your plan is to do. Now, as far as we know, we're going to do a needle decompression. We're riding over the third rib into the second intercostal space along the mid-clavicular line. Now, the alternative site is also to go ahead and mount the fourth intercostal space on the mid-axillary line, riding over the fifth rib. We just want to make sure that we stay away from any kind of great vessels, great organs, such as the myocardium. And if there is an issue on the lateral aspect, then we can come to almost that mid-clavicular line on the fifth, riding over the fifth rib. Now, follow your local protocols, but I'm just giving you some ideas of where we're going to go. Now, when we're doing it in the lower aspects of the lung fields or of the thorax, we're looking to drain blood. If we're trying to drain air, we'd probably go in the higher aspects, and we're looking at the second intercostal space, right over the third rib. Now, let's just go over anatomy real quick. Now, the first rib rides right under the clavicle, and that's right about where the suprasternal notch is, right up here. Now, as the suprasternal notch flattens out, we have the angle of Louis. The angle of Louis is about where the second rib is, and we want to go just under that, but we want to be careful, because if we go below that second rim, we end up hitting what? Those arteries, veins, blood vessels, and nerves that ride underneath that, and so we don't want to get underneath that. We want to hit the third rib and ride right over it. And that we would decompress the chest doing that way. Now, we've talked about decompressing the chest, and we want to use a large bore needle. We want to also use a long needle. It should be about at least 2.5, maybe a little greater, and these actually have to be special ordered, because sometimes we just don't carry them. It's usually about an inch and a quarter, or inch and a half, and they may not go through all the pectoral muscle or some muscles and tissue in the anterior chest wall. And basically, you're not going to get anything. So make sure you're using the right size and right depth and length and gauge of needle as you go into there. Now, we talked about using a type of seal, a one-way flapper valve. You can use a sterile glove or a finger of a sterile glove, or you could probably use a water seal. I mentioned that you can recap it and then go ahead and expire air out from that if you've seen signs of tension developing. Now, One of the greater, better signs of attention that is developing, attention pneumothorax, is that you have poor bed compliance. Now, if you're not intubated, you won't necessarily feel that poor bed compliance. Again, we'll see smaller EKG as far as its voltage goes, and you may see electrical alternators, which on respirations, the EKG changes as far as voltage goes, maybe larger in complexes and then smaller in complexes as it goes on.